Thank you. Once again, good to be with you all. So, in keeping in line with my prior talk today, this is largely a case presentation, not so much what would you do, but look at what I did. I actually have 3 cases. The first one's fairly straightforward. I'm going to jump to the third case. Did those other ones really fast. So here's case 3. He's a 46-year-old gentleman, had a motor vehicle accident in 1992, subsequently an acetabular fracture. His preoperative workup for infection was negative, and for me, that meant he had normal sed rate and CRP. He did have an aspiration, which we held for 14 days, showed no growth, and his hip motion is minimal. Would anyone consider fusing the hip or something like that? I didn't, but...
从李虎那儿开始。
So this is a challenger cases for the older pelvic fracture, and a lot of hardware stay in position, and even I think even the negative ESR and the CRP, we still consider infection for the if we do the total hip arthroplasty, and because we know that there are high infection rates for the hardware staying in position. Yeah.
Yes, no history of wound complications, but with prior surgery, particularly prior surgery for trauma, I would be especially concerned. Other thoughts? Would anyone not do a total hip replacement, or would that be the standard both in America and China? Yeah, go ahead, John.
I was just going to say that, I would have taken Michael's advice and done a hip replacement instead of fixing the acetabulum. But here we are now.
Yeah. He would have been in his early 30s, but I'm with you. I wasn't there. I was in high school. It was a good year. I'll discuss that at dinner. So this is just what a standard digital template setup would look like, again, with regard to the sizing. In reality, with two-dimensional imaging, I have no idea where that cup is going to be or what bone is truly there. Perhaps, not more importantly, but relevant to the mechanics of the surgery, I also don't have a great appreciation in a two-dimensional scan with where all the screws are. So typically, if I did this manually, I'll just make one more comment about the screws. As far as equipment, obviously I would have revision cups and of all sizes, etc. But I also have a metal cutting burr. My plan here would be to remove any hardware that got in my way. I would not routinely remove all the hardware. So again, using a robotic platform is my growing tendency. I have the ability to see with CT scan. I would love to show you the 3D modeling. However, the 3D modeling for the Mako is on a separate operating system. So I've selected some images to hopefully illustrate how you can preoperative plan. Here in these images, you'll see that the green represents the new implant. Anything pink in this picture represents either a bony landmark or the rim of the bone. You can see in particular how that one screw obviously needs to be removed or shortened because it will interfere with the placement of my cup. You can see it in multiple views to assure you have good bone contact and confirm your cup position. This stem is fairly straightforward. This is for sizing. You'll note it does say 8 degrees of femoral version. In this case, that's probably not so surprising, but in DDH cases, which seems to be a pattern, here in China, perhaps even more than we do, that number is quite valuable. You can see down in the box that versus the opposite hip, we're only 4 millimeters shorter based on landmarks high on the pelvis. Here we used an ASIS landmark because he had significant deformity of his pelvis otherwise. So this is essentially the program software, again demonstrating what our plan would be. This is not an X-ray, mind you. This is, again, the computer making something that looks like an X-ray for me. In reality, I'm going to follow this patient's X-ray for the rest of their life. I want to make sure that I like how the X-ray looks. That if they dislocate, I want to feel like the X-ray was my intent. In this plan, again, this is what we're planned, bottom right. We made him 10 millimeters longer than pre-op, which leaves him that 4 millimeters shorter. This is the post-op X-ray. I removed 2 screws. I did this with another surgeon. We removed 2 screws during this case. We used a single staging reaming technique. Reamed the acetabulum. Got good press fit. There is a screw in the acetabulum, although I could not convince you of that based on that X-ray. And then femoral sizing was appropriate. This is just to compare what the computer software did for us with regard to planning and what we should have developed and had. And then, of course, you see the true post-operative film on the left. Any questions or thoughts about utilization of this platform?
Looks like you have the implant a little bit more proud, so he's a little bit more equal in terms of leg length.
In truth, this is the plan. The plan was to put it, making the 4 millimeters different. I did not. I did not have on here the final intraoperative reduction, but yes, we equalized his leg length intraoperatively. Again, let me go back to this screen. This identical screen you can see in the operating room after you capture for leg length and offset. So I know that this is a planned image because it's planned. Typically intraoperatively, after I capture my landmarks in that same location, it would say reduced, and you would capture leg length and offset. So yes, in him I did equalize his offset. Again, I think it's really important, and we made this point earlier, the robot is helping me with the hard tissue, the reconstruction with the parts, but we cannot ignore the soft tissue, and particularly stability.
So I have a question. Before surgery, this X-ray showed a great abnormal structure, and then when you do a total hip, you have to remove a lot of bone ossifies, etc. Maybe that time maybe make the hip very loose. Then how can you get a very good range of motion? How can you balance the leg length? How can you make this hip very stable? What was your plan?
Yes. So it goes back to the comment John was mentioning to me. Our plan was to not regain the full length, thinking he would be contracted. However, intraoperatively, we could see he would tolerate longer length. Now, he had been short at this point, or he had at least been contracted since his MVA in the early 90s, so we didn't know how much length we would get back. The one advantage here, I like some of my other colleagues from the U.S., do a significant number of anterior approaches, but this was obviously done posterior approach with the same approach used for his surgery, and I have the ability to on-table test them. Now, there's probably a great discussion to be had about what on-table testing means and how it correlates to dislocation, but I can share with you my routine. They're obviously lateral positioned. I flex them to 90 degrees, and I see how much they'll internally rotate, and I document that, obviously. In this situation, by my assessment, he could flex to 90 degrees and interrotate 70 degrees before he impinged troche on the pelvis, and 75 degrees before he dislocated. He was able to achieve full extension with his hip, but could not hyperextend because we did lengthen him nearly 14 millimeters here. Yes?
So just to not lose track of the soft tissues, this guy's short and he's got a lot of extra bone. I would ask him a lot of questions about his sciatic nerve function at the time of the injury. And I would probably, I'm typically a nerve avoider. I don't find the nerve. This would probably be somebody that I would find that nerve on as I'm taking out that bone, because we're going to make him long and it may be encased in bone, and that would make me pretty nervous. So what did you do with the nerve?
I prayed for the nerve, Rob. It is an excellent point. I too do not typically uncover the sciatic nerve. In this case, I could feel his nerve quite readily, and it was not encased in bone. Combining that with my ability to add length, but realize after I removed the bone that I didn't feel like I was over lengthening him, I always also palpate the nerve at the completion of the procedure. Now, the problem with that is lots of people will palpate the nerve with the leg in a neutral position. I think it's very important to flex the hip up and see what their true functional, for example, sitting tension of the sciatic nerve is. So after completion of the procedure, his nerve was supple, and with a flexed hip, I did not think he had undue tension. But yes, I was scared.
Cory, I thought, have you, I mean, these things do not happen every day, but in some of these post-traumatic reconstructions, are you aware of people or your own experience with regards to the gluteus medius dysfunction? Maybe some initial injury or from doing these conversions, although using the posterior approach rather than the hardening, just splitting the gluteus medius, maybe injuring the superior gluteal nerve in traction and end up with dysfunction of that and therefore the tension issue.
Yeah, hip function so important, of course, after these cases. I'm actually, we'll be presenting a case tomorrow showing a complex acetabular reconstruction where you go high on the pelvic wall. I think this is one advantage of knowing exactly where you are in three-dimensional space and having a plan on which, I'm going to remove screw number 4, yada, yada. Having a plan for screw removal, because I do not feel compelled in this case to do further dissection up the acetabulum or up the iliac wing or around the posterior wall. Now, you bring up a good point. It could be scarred in, and just lengthening the limb would injure the superior gluteal nerve. I do not have much experience with that. My concern has been when the case required extensive dissection, like in a triflange case, and then I feel like I'm getting up to, where up above before it splits and causes a huge functional issue. I think the danger there is less in lengthening and more in the dissection. It's been my experience.
All right. Great. Thank you.
Thank you.